Welcome, everyone. Great to have you today. We have an exciting topic today, which is Medicare. We've all tried to pull our hair out over Medicare at different times in our lives. But I want to let you know that today we are going to be able to break some of that down for you. First, we're going to go over just a couple of little things, what I call housekeeping. Across the bottom on your bar, you will see a square with 2 C's in it, and that means closed captioning. If you'd like to turn that on, you will be able to see everything written out in closed caption, and that may help folks. What we are going to do is mute everyone, and so that when folks, while Donna's speaking, then she can, we'll open it up for questions and answers after our presentation. So we'll go ahead and do our introduction. Of course, the plane flies over right now. So hear the plane in the background for me. Okay, so I'd like to introduce to you Donna Delikat. She's the lead field officer for Senior Health Insurance Benefit Assistance. I'll say that again, Senior Health Insurance Benefit Assistance, which we call SHIBA. And she works under the Oregon Department of Human Services, Aging, and People with Disabilities. Where it's a pleasure to have you here again with us today, Donna, and I appreciate you sharing your expertise with us today.
Oh, it's my pleasure as well. Thank you. Right now, I have to tell you, we are pretty short-staffed in the state office. We did a big move from Department of Consumer and Business Services over to DHS, and pretty much the team I got moved. So I am SHIBA. I get to be Queen of SHIBA these days, which is kind of fun and a little stressful, I have to admit. So do you want to introduce anybody else, or do you want me to just go into my presentation? Go ahead. Okay. So I'm going to share my screen. Here we go. Can everybody see that? Should have Medicare 101 on there.
Yes, looks great.
Yes.
Okay, very good. This is just going to be a brief overview because we don't have very much time. I particularly did not add a whole bunch of detail because I thought if you wanted to take a tour of the Medicare.gov website and look for some of those prescriptions that would most likely be prescribed for somebody with ALS, then we could do that as well, or we could just open it up for Q&A at the end. So we're going to be pretty fast, just give an overview and then work on some specifics as needed, okay? All right, so Medicare is broken up into 4 parts. You can see A, B, C, and D. We've got lots of alphabet soup in this program. A is hospital insurance, which is usually premium free if you have a work history or you were married to somebody who had a work history. It comes automatically whenever you file for any kind of Social Security, retirement, or disability benefits. If you are eligible for Social Security disability, then once that Medicare kicks in, A and B are going to automatically kick in. Part B is optional. It does have a monthly premium. Part C is contracted Medicare. That's why I try and remember the C is contracted Medicare. So just like your employer might have had contracts with certain insurance companies as an employee, Medicare has certain contracts with certain companies that offer all the Medicare benefits, not necessarily at the same cost, but they can add more benefits if that is of interest to somebody. They try and sweeten the deal a little bit. Part D came about in 2006, and that is the prescription drug portion of Medicare. So now we've got A, B, C, and D. I don't know what they're going to call dental if they ever get dental added to the Medicare program, because we can't have 2 Ds, right? T, teeth. Who knows? Anyway, that's a big discussion that's going on in Congress right now is should we add additional benefits to the Medicare program? Because as you may know, Medicare doesn't cover a lot of things, and dental is the #2 call that we get in our office. So we're going to kind of look at how you would structure your package to make the most of your benefits, but also at the lowest cost if it's available. So the first thing I usually tell people is when you have eligibility into Medicare, your foundation is going to be that A and B. Most often, people are going to pick up both of those. Even though B is optional, there's very little, if any, other insurance out there other than maybe an employer plan if your spouse is working that's going to cover an older person. So A and B is pretty much the starting point for everything. The next thing that people might want to look at is adding prescription coverage, because A and B only cover prescriptions in certain circumstances. A, obviously, if you admitted to the hospital as an inpatient. B, if you're going to an infusion clinic, or maybe you've got an injectable that only a clinician can inject, you can't self-administer it. So that's the times when B might cover a medication. Everything else that you purchase at your local pharmacy or have mail order pharmacy and is self-administered comes under Part D, as in drug prescription coverage. And that can vary depending upon medication needs. Right now, the cheapest plan starts at $6.30 a month and goes up to over $100 a month, depending upon the medications that are being prescribed. Lots of times folks think, oh, this is plenty, but they don't realize that when they start on Medicare, Medicare has some pretty hefty out-of-pocket costs. And to avoid having those out-of-pocket costs hit you when you least expect it, folks will pick up secondary insurance. Secondary insurance works with original Medicare A and B. So if you have an inpatient hospital stay or you have any medical services that fall under B, that's when that secondary insurance would kick in. So that could most likely be a Medigap policy. The legal name for that is Medicare Supplement. In my world, supplement is very specific to a secondary policy. Right underneath that, we've got retiree benefits. Sometimes retiree plans, most often retiree plans require their retirees to be enrolled in both A and B. The only retiree plan that I know for certain that doesn't is if you're a federal retiree. But even federal employees or retirees will often enroll in both A and B because it's going to reduce their out-of-pocket costs. Sometimes we have folks that work past age 65 and they might work for a very small employer. So Medicare protects small employers, and we'll get to the definition of small in another slide. Small employers have a higher cost of insuring older workers, or workers who are on Medicare due to disability. So Medicare says we'll be primary in certain circumstances, and you employer, you can have secondary coverage, and that's going to lower their monthly premiums for that employer. And then the last two are the payers of last resort. If you happen to be a registered member of an Indian tribe, or you are eligible for the Medicaid program. The Medicaid program is based on financial income and family size for the most part. There's full Medicaid, and that would have additional eligibility criteria. So that's one way you can put together your Medicare package. The second way that you can put your Medicare package together is to go through that contracted Medicare, otherwise known as Medicare Advantage. So instead of having multiple cards, a Medicare card, a prescription drug card, a secondary insurance card, you're going to have one card, and you're going to be enrolled in a plan with a particular insurance company that is contracted with Medicare. So that could be in your area, Pacific Source or Providence or Moda, or I'm trying to think of something, United Healthcare. We've got lots of companies in Oregon that contract with Medicare. We're very fortunate. The vast majority of those options are in the Valley, right along the I-5 corridor. As you get further out, either to the coast or to central and eastern Oregon, those options get thinner and thinner because it really is population based. And so sometimes there's not as many options when you're living at the coast or in eastern Oregon as there would be if you were living in the Portland metro area, let's say. But in order to have a Medicare Advantage plan, again, you're starting with that same foundation. You have Medicare A and B, but instead of having your claims go to the federal government, they're actually going to get processed by this contracted Medicare Advantage plan. In fact, that plan is responsible for managing all your benefits, determining whether or not you are covered for a particular service. You might have a prior authorization, and you might end up having a network that you have to stay within. So they have much tighter controls. It's managed care. Some people like it, some people don't like it. There are advantages to one side or the other, depending upon what your circumstances are. So let's just take a really brief view of what Medicare Part A looks like. So Medicare Part A is usually premium free. Somebody has worked, they've earned wages, they've paid taxes on those wages, and as we pay those taxes, we are earning credits. Credits towards our Social Security retirement and credits towards our premium free Part A coverage. If you have earned enough credits to get Social Security retirement or disability, usually it's 40, sometimes it's less if you're on Social Security disability, then you have no monthly premium for Part A. Occasionally we will find people who didn't work enough, or they didn't work in the United States, maybe they worked outside the US, they would be able to buy Medicare Part A, but it's kind of spendy. It's $471 per month. At least that's the price this year. We don't know what the price is for next year. Part A has something called a benefit period deductible. And a benefit period deductible is different than an annual deductible. A benefit period says when you go into the hospital and you are admitted as an inpatient, that's the start of your benefit period. When you get discharged from the hospital, the clock starts ticking and you have 60 days to come back to the hospital in the same benefit period. If you are discharged from the hospital for 60 consecutive days or longer, now your benefit period has ended. So what does that mean? Well, it just means that that hefty deductible can repeat in the same year if you are hospitalized more than once. So long as you are discharged for 60 consecutive days in between those hospital stays, that is going to open up a new benefit period, and you're going to start at the very beginning. What happens if you go back to the hospital within that 60 days? Well, you just pick up right where you left off. So if you were in the hospital for 10 days and you got discharged and now you came back a couple weeks, a month later, you haven't exceeded 60 consecutive days, you're going to start back in the hospital at day 11. And that's going to determine your daily charges, because Medicare says 60 days in the hospital is covered by that deductible. If you exceed 60 days in the hospital, now you're going to have a daily charge. Part A is by and large coverage for the hospital facility. It is not for a lot of the services that go on in that hospital. So if you're going to have surgery in the hospital, like let's just say a hip replacement, God forbid, that surgeon and the anesthesiologist, they're all going to charge their services to Part B medical, just your room and board, general nursing, supplies, and medications while you're in that facility, that hospital room, are going to be charged to Part A. And that's sometimes, you know, the big difference in whether or not you're in the hospital under observation or if you're actually admitted as an inpatient. If you are actually admitted as an inpatient and you have spent at least 3 midnights in that hospital room, in that bed, you have an additional benefit called the skilled nursing benefit. Skilled nursing allows you to transfer from that hospital to a rehab center where you can get daily physical therapy, daily occupational therapy, wound care, whatever it is that that patient needs in a skilled nursing environment. And that 3 midnight hospital stay qualified that patient for 20 days of rehab at no additional charge. That 20-day rehab, zero copay is covered by that initial deductible. If you happen to need more therapy than the 20 days and your doctor writes the order, yes, you can stay in rehab longer. It's just going to cost you a daily charge. So you can kind of see why some people would want to have additional insurance if they're racking up all these deductibles and daily charges while they're in the hospital or in skilled rehab. Some people don't want to go to skilled rehab. They would rather go home. Who doesn't, right? Everybody wants to go home after they've been in the hospital. So home health is available as long as it's physician ordered through a home health agency that's been contracted with Medicare, and you have a skilled need. So they have to bring in somebody who is going to perform physical therapy, occupational therapy, wound care, whatever the skilled need is. It's not for bathing or meal prep or anything like that, although some of those home care situations can include that if you have a skilled need. Part B, on the other hand, is the heavy lifter of the Medicare program. It covers just about anything and everything that is medically necessary, whether you're out of the hospital at the clinic, in the physician's office, in the emergency room, or in the hospital having surgery. This has a monthly premium of $148.50 for most people. It is means tested, meaning that they're going to look at your most recent tax return and determine if you are a quote unquote high income earner, a single person of $87,000 a year or more, or a couple, double that, $174,000 a year or more, your premium is going to be higher. This particular side of Medicare has a true annual deductible. So when you go get services the first time in the year, Medicare says, oh, you haven't met your deductible yet. We're going to take $203 right off the top. And now after that $203, we are going to cover 80%. And you, Medicare beneficiary, you have a 20% co-insurance, like a copay, only a percentage. The problem with this, it sounds pretty good. 80-20 is, pretty good coverage. But the problem here is there's no maximum out of your pocket. 20% of $100, even $1,000 doesn't sound too scary. 20% of $100,000, that would scare me. So that's why a lot of folks will get secondary insurance to pick up that 20% at the very least. They don't want to have that unknown out there, hitting them financially when they're going to be least prepared for it. So as I said, Medicare is pretty much, or Part B is pretty much the heavy lifter. All those services that you see there, including observation stays in the hospital. A lot of time we don't know whether or not we're in the hospital under observation or if we're an inpatient. So you almost have to ask, but now Medicare has a special notification that is required if you happen to be in observation status for more than 24 hours. So hospitals are now required to inform somebody when they're not admitted as an inpatient. If we go to the hospital through the emergency room and we don't really know what's wrong with us, maybe I've got a terrible pain in my abdomen and I've never had abdomen issues, they're going to run some tests and determine what's wrong with me, and they might put me in a hospital bed and observe me for a while I am getting that diagnostic testing results back. Up until the early 2000s, Medicare really didn't cover any non-medically necessary services, but that changed. We now have preventive services that are available, and those are screenings to keep you healthy longer. I recommend that people take advantage of those screenings. It could be a cholesterol check, it could be blood pressure check, it could be lots of breast cancer, mammograms. A lot of those are silent killers, and we really want to get on top of those sooner than later because early intervention has better outcomes. That's a non-controversial statement. It works every time. So the sooner you can find out that you've got something, the better off we are. There is an entire publication dedicated just to preventive services. There might be some timelines associated with getting them, so make sure you understand what those timelines are so you're not having to pay out of pocket. That last little pink line down there just reminds me that everybody should be looking for accuracy on their Medicare statements. We have about $60 to $90 billion a year in Medicare fraud, billion with a B. And so the only way that we can stem that hemorrhaging of Medicare dollars is to make sure that people are aware and they know how to report it if they think that there is fraud going on. The first thing, of course, is to review your Medicare summary notices. They come quarterly, which sometimes, has an awful lot of services on it. Go back to your calendar, make sure you can identify all the things that Medicare got charged for and review them, make sure they're legitimate. If you have a question, it's not a problem. Ask your providers, for clarification. It could be a human error that they could fix easily. It could be something that is much more nefarious. So we want to make sure that folks aren't getting their Medicare benefits charged for things that they either didn't receive or they didn't need. A new benefit that just came around last January to stem the opioid epidemic is Medicare now offers acupuncture for low back pain, chronic low back pain. Chronic just means it's been persistent for 8 to 10 weeks. The problem we're seeing right now, though, with any new benefit, there's always going to be a few hiccups as we implement that new benefit. Very few physicians have an acupuncturist in their clinic, and it has to be billed under a medical doctor who's contracted with Medicare. You can't just go to your alternative care practitioner because Medicare doesn't contract directly with acupuncturists. It has to go through some clinic to get that clinic's Medicare contract billed through, not just the acupuncturist. So a little bit of a tangled web there if you need that. I mentioned that Medicare does not cover a lot of things. Annual physicals is one. There is something called an annual wellness visit. It's basically a talking appointment. You have no complaints. You're just going in to talk to your physician or your clinician, if it's not an MD or a DO. What preventive services should I get this year? What's my family history? What medications am I on? Should I have my cholesterol checked? Should I schedule my routine mammogram screening for this year? Those kinds of things. It's not, oh, by the way, I have an earache and you need to tell me why I have the earache. It's a wellness visit. The other thing that Medicare does not cover is routine vision, unless you have a health issue of the eye. So just to go in and get your glasses prescription updated and your glasses, new pair of glasses, not going to work. But if you have glaucoma or macular degeneration or cataracts or something that is medical in nature, Medicare covers that. And folks who have been diagnosed as diabetic do get to have an annual vision check because diabetes can adversely affect their eyesight with retinopathy usually. Dental is the big thing that's being discussed right now at the congressional level. I would say the number 2 call coming into our call center is, I need dental and I don't know where to get it. I don't have any insurance. It's really expensive. Do you have any low-cost clinics? Not a lot of resources out there, to be honest. We have some dental insurance plans that will offer limited coverage. I would say check with your preferred dentist to see what insurances they might accept and then maybe go from there. We do have a list that one of our counselors is updating for 2021 with dental insurance companies and plans that are available in the state of Oregon. Figure anywhere from $40 to $60 a month, and progressive benefits, meaning you get your cleanings, x-rays, and exams at the very beginning, but you have to wait 6 months to a year to get any kind of restorative or comprehensive services like crowns and root canals. Hearing aids are another pretty spendy proposition. Medical devices that are tuned to your hearing deficits run about $2,500 to $3,000 starting for a pair of hearing aids. Pretty spendy. There are hearing aids now that are just strictly amplification. So if you're not sure you want to spend the money on a medical device, you can look for amplification. The FDA has approved amplification hearing aids that just increase the sound, just like the glasses at the local drugstore magnify the size of the print. So it's not a medical device, it's simply an aid. That last bullet there, long-term custodial care, refers to when someone can no longer take care of themselves in their own home. Medicare does not cover custodial care. Custodial care, if you cannot afford to pay for it yourself, is usually through the state of Oregon, and you have to apply for Medicaid to come in with some services. Or if you are needing to go live in an assisted living facility, Medicaid would take a look at your eligibility to have that assisted living community rent paid for by the state. All of that is done through the Aging and People with Disabilities offices or the ADRC of Oregon, Aging and Disability Resource Connection. When I mentioned secondary insurance, most commonly folks are going to be looking at Medigap policies. The legal term is Medicare supplement, but most people refer to it in the slang term of Medigap. And this type of insurance has 10 different levels of coverage. Right now, what's most available for the most coverage is called a Plan G, got more alphabets in here. G as in George, covers everything that Medicare A and B would say is your responsibility after you've met that $203 deductible. So G does not cover the Part B deductible, but it covers everything else. It used to be called Plan F, but F is no longer being sold to new Medicare beneficiaries. And it is actually quite quickly pricing itself out of the market because we have no new people coming in, keeping the prices down. SHIBA counselors, depending on where you live, we have access to a actuarial tool that can run rate comparisons if you are interested in getting some pricing for the various plan letters, A through N, G being the most comprehensive, and it's based on age, zip code, and tobacco use. If you have a guaranteed issue period in which you are guaranteed to get a policy, those are the only 4 things that somebody or a company is allowed to ask. And that pretty much is the best time to buy a Medigap policy. When does guaranteed issue come around? When you first come on to Medicare, when your Part B, as in boy, starts, that effective date starts the clock ticking, and you have 6 full months with guaranteed issue, meaning the company cannot factor in any pre-existing conditions, and they are required to issue you a policy based on the answers to those 4 questions: zip code, age, gender, and tobacco use. If you are covered by another insurance plan and that insurance plan is ending, maybe it's a COBRA policy, maybe it's an employer policy, you have 63 days, much shorter window, but you still have 63 days to purchase a Medigap policy, and the company would be required to issue you that policy without having to ask any medical underwriting questions. So those are the best times to enroll or to purchase a Medigap policy. Other insurance might work and coordinate with Medicare, certainly employee coverage. If the employer has less than 20 employees, then Medicare is going to be primary. Unless you are on Medicare due to a disability and you're under age 65, then it has to be the employer has to have less than 100 employees to be primary. If it's over those 2 amounts, then the employer plan is primary. And that can make a pretty big difference on whether or not you enroll in Medicare. So always check with your HR department if you think that that might be questionable, whether they are above or below 20 or 100. Retiree coverage is most often secondary to Medicare, as I mentioned. TRICARE for life for retired military professionals, like people who spent 18 or more years in the military, or CHAMP VA benefits. CHAMP VA is the program for 100% disabled vet dependents. And then, of course, the last payer of last resort is the Medicaid program, which is that last bullet. If you do need assistance with the cost of Medicare, there is a Medicare savings program, and that is through the Aging and People with Disabilities Office. It is financially determined. So depending upon what your gross monthly income is and your family size, you can see single person $1,469 monthly or less, and a couple 1980, that would at least get the Part B Medicare premium paid for by the state. If your income is even lower, the state might pick up the 20% and or some of the other costs associated with Medicare. So in order to qualify for that, you do have to call the state to make your application, and you see the phone number on there. And I can provide the handout of this slide for those phone numbers at a later date. I'll send it through to the coordinator. Part D, drug coverage, came about in 2006. It covers those self-administered medications that I mentioned that you buy at your local pharmacy or you purchase through a mail order pharmacy. Right now, I think I said the starting point is $6.30 a month. I think that's going up to $7.70 in 2022. We haven't got the 2022 plan information yet. That becomes publicly available after October 1st for next year. But I did want to show you a little bit about how you could find a plan after October 1st. So if you want to go to Medicare.gov, we do recommend that you check this every single year because plan benefits do change from year to year. These are only 1-year plans. Then there might be a new competitor out there that unless you go look at it on Medicare.gov, you won't realize that there's something that's going to give you better coverage at a lower cost to you every fall during that open enrollment period, October 15th to December 7th. If you haven't created an account on Medicare.gov yet, I do recommend that you do that. Not only does that help you with a lot of information that's on Medicare, it also saves your medications so you don't have to re-enter them every year. Because if you just go through the find plans and put in your zip code, you're going to have to re-enter your medications each time you visit the Medicare.gov website. But if you create an account, it remembers you and you have a login and a password, and then you can get your information back right away. This next slide is a little busy. I'm going to walk through it. This is 2021 benefits, and we do have 2022 benefit information I included in the next slide. So basically, the colors do have meaning. I wasn't just having fun being colorful. All the yellow squares are the dollars that are coming out of your pocket. So Medicare says this standard benefit is the minimum that any prescription plan that's contracted with Medicare must follow. If they want to do better than this, they can, but they cannot do worse. So a plan must not have a deductible of more than $445 this year. Lots of plans don't have a deductible, but if they do, it cannot be more than $445. Once you meet that deductible, you're going to go into stage 2. And now the plan has a tiering structure, and every medication that is taken is, or on their list of drugs that they cover, their formulary, is listed as tier 1 through 6. And the tiers just tell you what the price is going to be when you go to buy it at the pharmacy. Tiers 1 and 2 are generally generics. Tiers 3 and 4 are generally brand names. Tier 5 is usually a specialty drug, and it usually has a higher co-insurance, a percentage. But on average, that plan has to cover 75% of the cost of your medications. And on average, you're going to end up paying about 25%. And the reason why I say on average is because maybe you have 3 generics and you can get those at 0 copay, and you have 1 brand name and it's 33% co-insurance. So on average, it's going to work out to be about 75-25. So it's not actually, and each drug is not 25%. When you have a total drug value, meaning what you pay and what the insurance company pays, you get to that green bar at the top, $4,130. So green represents the blue and the yellow boxes below it. If you exceed $4,130 in total value of drugs, you now exit stage 2 and you go into stage 3, where there is a true 25% co-insurance. Whatever that company or plan says is their full cost, you're going to pay 25%, whether it's a generic or a brand name drug. On the left side of stage 3, you'll see a pink square, and it says 70% manufacturer's discount. When you are purchasing a brand name drug, even though you are paying 25% for that drug, you actually get credit for 95% coming out of your pocket, because that manufacturer's discount is added to your, at the bottom, TROOP. TROOP stands for true out of pocket, which is kind of a misnomer now because it's not actually what's coming out of your pocket. You're getting credit for that 70% that the manufacturer is discounting. So that's why I made it orange, because yellow, all but what's coming out of your pocket, plus pink makes orange. I had to do this for my own mental understanding, so I figure I would share it with you as well. If you do have very expensive medications, and lots of people do, my family has multiple sclerosis, and some of their injections run about $6,000 a month. So right off the bat, if they purchase one medication they're going to have $6,000 in total value. That's going to propel them into stage 3 right away. And then the next time they buy that prescription, they're probably going to get out of stage 3 and into stage 4, because now they have satisfied that $6,550 troop amount. And stage 4 says you're only going to pay 5%. But even at 5%, a $6,000 prescription is $300 a month. So we're always looking for ways to save people money when it comes to their prescriptions. Here's what's changing for next year. The deductible is going up to $480 from $445. The troop is going up to $7,050. This year it's $6,550. So it is going to affect our out-of-pocket costs a little bit. And that total value of drugs, that green bar at the top, is increasing by 300. Instead of 41, it's 44.30. So just to give you a heads up, there might be some, increases in your cost share when you get to drug program next year. We do have a financial assistance program for prescriptions as well. It is through the federal government, not through the state. It's called limited income subsidy, but we also put a more friendly term on it called the extra help program. It is determined by income and resources. So if you have income that meets the eligibility, that's not the end of the means testing. You have to disclose whether or not you have resources in excess of those dollar amounts. However, if you are eligible for state financial assistance, the state doesn't count resources, so you would automatically get this benefit. The federal government says, okay, if you have Oregon benefits, we're going to let you have this extra help with the prescriptions. What does it provide? It provides a subsidy towards the premium on the drug side of the equation, whether that's a standalone drug plan or a Medicare Advantage plan, and it lowers your cost shares to no more than 15% co-insurance. So that's going to really reduce that 25% in any stage down to 15%, but you always get the price that is going to give you the most savings. So if your plan says, no, you're only going to have a $50 copay and 15% would be $75, you get the $50 copay. So you always get the lower cost of the two options. We do have a toll-free statewide call center number. That's the SHIBA state call center. We can screen for eligibility and provide assistance with that application if you call us. Or we have a Medicare Savings Connect phone number that can do the same thing. So you got two resources there for applying for the extra help program. The last thing we have is Medicare Part C, which is Medicare Advantage. And that's that contracted Medicare. The reason why a lot of people might get Medicare Advantage is because they either missed their opportunity to get into a Medicare supplement, Medigap policy, and they can't pass medical underwriting. Part C, Medicare Advantage plans take everybody. They're contracted with Medicare to take everybody, regardless of age, health status, or ability to pay. They take everybody. So the two things that you must have is you must be enrolled in both A and B, because that's what they're managing, and you have to live in that plan service area. Remember, I said there's lots of options in the I-5 corridor, but there's also options all over the state. So we can help determine what those options are if you need us to. The main thing to think about with Medicare Advantage is you are deciding to enroll in a privately contracted Medicare plan. That means that you need to follow whatever that company's process is, if it's an HMO or a PPO, you might need a prior authorization or a referral to go get services. So make sure you talk to your plan, because they're in the primary position. All your claims, all your customer service, all your appeals, suppliers have to go through that plan. And they might offer some extra benefits to sweeten the deal. So if dental is a big thing for you, or you want to have that fitness club membership, or maybe they offer transportation to medical appointments, Medicare Advantage plans are expanding the list of additional benefits in those plans. I'm really excited to see what 2022 benefits are going to be offered by some of these plans, because I know they're really competitive, and lots of people are looking at those extra benefits when they're making their choice of which plan to go with. In Oregon, we have HMOs. Think about Kaiser. If you want to go to Kaiser, you have to be in a Kaiser plan. Usually you're going to see Kaiser doctors, go to the Kaiser pharmacy. It's a health maintenance organization that manages all your benefits within their network. If you go outside their network without a referral, you have no benefits. But if you need to have services and they can't provide that, my mom had a very serious eye issue. Their eye services would not include the surgery my mom needed. She got a referral to go to the KCI clinic, and she had her surgery at KCI. If she hadn't had her referral, she would have paid 100% out of pocket. But since she had a referral, it was just like going in network with Kaiser. Some HMOs have something called point of service. That just means you can go outside the network, but you're going to pay more. And that physician must be Medicare contracted. It's probably about 30 to 50% of the Medicare contracted rate for out of service, point of service services. Another type of plan we have is PPOs, preferred provider organizations. Kind of what it sounds. We would like you to go see our network of preferred providers. You have an in-network rate, but you're still going to have benefits if you go out of network, and you have a higher out-of-pocket cost if you seek out-of-network services. The concern I have here is that not all physicians will accept all insurance plans. So be very, very careful that you check with those physicians before you go get services, whether or not they will bill to your plan. Because if they don't want to bill to your plan, then you're kind of stuck holding the claim, and you're going to end up paying more for it. You want to make sure that those providers are going to accept and bill to whatever insurance Medicare Advantage plan you have. We have something new in Oregon that started this year. It's called a medical savings account. We don't know a whole lot about them other than it is considered what's called consumer directed. There's two steps to it. You have a high deductible health plan, and in Oregon we have a $5,000 deductible plan and an $8,000 deductible plan. And there is a medical savings account that plan deposits money into that you can use during that deductible period. However, the money they deposit does not cover the full deductible. For the $5,000 deductible plan, it only deposits $2,000 in your account. For the $8,000 deductible plan, it only deposits $3,000. So you're going to have some out-of-pocket costs until you reach that deductible, and now the plan is going to pick up 100% of the cost of your services. When you are in that deductible period, you are going to pay 100% of the Medicare assigned rate. And you can reimburse yourself out of that savings account, but at some point that money is going to go away, and now you're going to be paying out of pocket until you reach that deductible. For most intents and purposes, this is an IRS controlled type of medical savings account, and you have to prove on your tax return that you used that money for medical services. If you used it for anything other than an IRS qualified healthcare amount, then you are going to get taxed as if it was income, and you're probably going to pay a penalty. So it's really not for people who aren't financially savvy and can, jump through all the hoops that are required. And if you use it for things that are Medicare covered, it's going to go towards your deductible, but it doesn't mean that you can't use it for qualified healthcare costs that aren't Medicare covered. So if you want to use that $2,000 towards a pair of dentures, that is an IRS qualified healthcare cost, but it's not a Medicare covered medical expense. So you can see where it can really get people in a little hot water if they are not totally understanding how to use this plan. And I already said that you have to file a tax return. The plan's going to send you a form showing you what was withdrawn from that medical savings account, and you have to account for the money that was withdrawn. So we've only got 8 minutes left. How to enroll in Medicare? Automatic if you're age 65 or older and you're receiving some kind of retirement or disability benefits. You have to apply if you're not receiving those retirement or disability benefits. There is a 7-month period called the initial enrollment period in order to get into Medicare. And you have to go through Social Security. They are the enrolling agency for Medicare. If you are applying for and receiving Social Security cash benefits, Medicare will automatically begin on the 25th month of those cash payments.
And for people with ALS, it actually is a Medicare triggered when Social Security disability is applied for, and usually they get it within 3 months.
Very good. Yes, I was just going to mention that too, that it's fast tracked for ALS and people with ESRD, end-stage renal disease. Thank you, Mary. Here's a IEP. The birth month is right in the middle. 6 months or 3 months before, 3 months after, and the month you turn 65. We counsel a lot of people who might miss this period. So hopefully nobody in your friends and family or social network is going to miss that period. So that's really important. If you're still working, you can delay enrolling in Medicare without penalty as long as you have group health insurance. So in my family situation, I'm still working. I have group health insurance. My husband is Medicare eligible. He is not on Medicare Part B because he's covered under my insurance. He's exempt from any kind of penalty because when I get ready to retire, I'm going to get a piece of paper that proves that he had group health insurance through my employer. Oh, I think we can miss this. That's not going to really apply to you guys. I'm conscious of our time here. Medicare Advantage or prescription drugs, obviously you can enroll in those when you become first eligible for Medicare, or we have some specific enrollment periods. So one that's coming up right now is the annual enrollment period. That starts October 15th and ends December 7th, and it's going to kick in for the next calendar year. We also have something called the Medicare Advantage open enrollment period. That started a couple years ago. I think mainly because sometimes we have contract negotiations that occur up until the last minute in the calendar year, and maybe your physician decided, I'm not going to contract with that Medicare Advantage plan anymore. And now you just found out, hey, patient, if you still have this Medicare Advantage plan, we're not going to see you anymore because we don't take your insurance. It gives you an opportunity to switch to another Medicare Advantage plan that your physician does contract with. So you get one opportunity to make a change in that January, February, March timeline. Please make the choice to enroll in what you want, not to disenroll from what you don't want, because disenrolling from what you don't want is using up your one choice. If you enroll in what you want, it automatically terminates what you don't want. And then we literally have 14 pages of special enrollment situations. So certainly if you have a special circumstance and you want to run it by us, we will tell you if you have a special enrollment situation. Not going to worry about late enrollment penalties. I should have just taken those off. Final thoughts. Obviously, you've got great resources through the ALS Association, and they've got my ear. So anytime you need assistance with your Medicare, please reach out. We're here to help. Get your information from an official source. SHIBA is contracted by the Administration on Community Living to be your local Medicare information resource. The closest Medicare office is actually in Seattle, and they handle all of Oregon, Washington, Idaho, and Alaska. So using SHIBA is like using your local Medicare office because I talk to them on a daily basis. If you are talking to a federal employee at Social Security or 1-800-Medicare, please know that if you document those conversations, that you have protection if you got wrong or inadequate information and you made a decision that ultimately harmed you. If you have that good documentation, you can ask for getting it fixed at no harm to you. And I encourage you all to talk to a SHIBA counselor if you are thinking about making some changes. After October 1st, we will have 2022 plan information, and we have a number of counselors who are very anxious to get started in our open enrollment activities. That's all I got. I didn't leave much time for questions. I'm so sorry.
That's fine. Thank you very much, Donna. I think the key thing that I take away from this is call and make an appointment right away. So you'll be ready for that October 1st, be able to get into talking with a SHIBA counselor over the phone. And remember, each county may have a different program. So it's very difficult for your care services coordinator to know every single insurance and what county it's covering. So please know, great resource and continually use them.